Question 1. A 48-year-old woman presents with progressive dyspnea and orthopnea. She reports intermittent palpitations and decreased exercise tolerance for the past 2 years. She emigrated from rural Nepal 3 years ago. Physical exam reveals a tapping apex beat, loud S1, and an early diastolic rumbling murmur at the apex that increases during expiration. ECG shows atrial enlargement. Suddenly, she develops severe left-sided weakness. Which of the following is the most likely mechanism of her neurologic deficit? The most likely answer is B, cardioembolic stroke. This woman's presentation is characteristic of rheumatic mitral stenosis, marked by a loud S1, an apical diastolic rumble, progressive dyspnea, and a background of residence in a region where rheumatic fever is prevalent. Mitral stenosis frequently leads to left atrial enlargement and stagnant blood flow, creating a high risk for left atrial thrombus formation. If such a thrombus embolizes, it can abruptly occlude a cerebral artery, producing the sudden onset left-sided weakness observed here, classic for a cardioembolic stroke. By contrast, atherosclerotic plaque rupture generally causes myocardial infarction or large vessel stroke, but is far less expected in a younger woman lacking conventional vascular risk factors. Likewise, a paradoxical embolism would require a right-to-left shunt, such as a patent foramen ovale, which is not suggested in her examination or history. Furthermore, vertebral artery dissection typically manifests with posterior circulation deficits, such as vertigo, diplopia, or ataxia, rather than isolated hemispheric weakness. Therefore, atherosclerotic plaque rupture, paradoxical embolism, and vertebral artery dissection are unlikely to be the correct diagnoses. Question 2. A 57-year-old man presents with acute shortness of breath and chest pain. He has COPD and takes inhaled steroids. He is tachypneic with decreased breath sounds on the right, hyperresonance to percussion, and tracheal deviation to the left. BP is 7240 millimeters of mercury. What is the next best step? The correct option is choice A, needle thoracostomy. This patient presents with sudden dyspnea, unilateral absent breath sounds, hyperresonance, hypotension, and tracheal deviation, classic features of tension pneumothorax. The immediate life-saving treatment is needle thoracostomy to relieve intrathoracic pressure. In contrast, intubation does not resolve the trapped air and may worsen the condition. Similarly, CT of the chest is not performed first in an unstable patient, and thoracentesis is used for pleural effusion, not tension pneumothorax. Therefore, intubation, CT chest, and thoracentesis cannot be the correct interventions. Question 3. A 42-year-old alcoholic male presents with abdominal pain, fever, and jaundice. Laboratory results show AST 240. ALT is 90, bilirubin is 7.8 milligrams Bellers, INR is 1.9, and there is neutrophilic leukocytosis. Ultrasound shows a fatty liver but no obstruction. MADRI score is 38. Which of the following is the best initial management? The most appropriate answer is C, prednisolone. This patient shows classic signs of severe alcoholic hepatitis, elevated bilirubin, AST greater than ALT with a ratio more than 2, coagulopathy of INR 1.9, and a MADRI discriminant function above 32. The first-line treatment is corticosteroids such as prednisolone to reduce short-term mortality. But N-acetylcysteine cannot be the answer because it is used for acetaminophen toxicity. Choice B, broad-spectrum antibiotics are reserved for documented infections. Similarly, ursodeoxycholic acid is indicated for cholestatic liver disease, not alcoholic hepatitis. The MADRI score is a clinical scoring system used to assess the severity of alcoholic hepatitis and guide treatment. Here is the method for calculating the MADRI score and its clinical interpretation. Question 4. A 29-year-old woman presents with anxiety, weight loss, and heat intolerance. She also has oligomenorrhea and difficulty conceiving. Exam reveals coarse tremor and a diffusely enlarged non-tender thyroid. Laboratory results show suppressed TSH and elevated T3, T4. Luteinizing hormone and follicle-stimulating hormone are low. What is the most likely cause of her menstrual abnormality? The best answer is C, low gonadotropin-releasing hormone. This patient has hyperthyroidism, most likely due to Graves' disease, as indicated by weight loss, heat intolerance, tremor, and a diffusely enlarged thyroid. Hyperthyroidism can suppress hypothalamic gonadotropin-releasing hormone secretion, which lowers luteinizing hormone and follicle-stimulating hormone levels and leads to oligomenorrhea and infertility. In contrast, a pituitary adenoma would typically present with either elevated or low specific pituitary hormones, and often visual symptoms, not hypothalamic suppression of luteinizing hormone and follicle-stimulating hormone. Low progesterone is a secondary effect of low luteinizing hormone and follicle-stimulating hormone rather than a primary cause. Hyperprolactinemia can also cause menstrual irregularities, but there is no evidence of galactorrhea or elevated prolactin, and the patient exhibits clear hyperthyroid features. Therefore, these alternatives are less likely. Question 5. A 3-year-old unvaccinated child presents with fever, inspiratory stridor, and drooling. He sits leaning forward and refuses to lie down. His voice is muffled. Lateral neck radiograph shows a swollen epiglottis. What is the next best step? The clinical findings point to choice D, endotracheal intubation. This child presents with acute epiglottitis, as evidenced by fever, drooling, muffled voice, inspiratory stridor, and the classic tripod posture. Because the airway is at immediate risk of obstruction, securing it is the top priority, and endotracheal intubation in a controlled setting is the next best step to prevent sudden airway collapse. In contrast, a throat swab for culture is dangerous because manipulating the airway can trigger complete obstruction. IV corticosteroids alone may reduce inflammation, but do not protect the airway, which is critically threatened. Similarly, nebulized epinephrine is effective in croup, but not in epiglottitis, and does not prevent airway collapse. Therefore, these interventions are not appropriate first-line measures.